copy of it. Okay, so we started to record now, yeah? So we're doing feet and hands, and let's see how we get on. So, okay, so what do you think? What is this?
This is radiograph of knee of skeletally immature patient showing
there's a big yellow pointing it, telling you what it is.
Yes. Fracture at the corner of the distal femoral condyle, consistent with metaphyseal corner fracture.
So where have you seen one of these before?
Not here, but I have seen this in
this. So can you see there are rib fractures?
Multiple. Yes.
Yeah, and they're all healing. They're not new, so they're all healing. So that always comes together. What does that mean?
That is non-accidental injury.
Very good. So how would you know that this is a non-accidental injury? This is a 1-year-old child.
So because of different stages of healing of the fractures at multiple sites.
I'm not talking about this now. If somebody tells you that this is a 1-year-old and this is the injury, that what will make you suspicious that this is a non-accidental injury in the history?
Because in a non-ambulatory child,
long bones don't break, you can say. Exactly. If you have a long bone fracture and the child is not walking, then that's a non-accidental injury, okay? So what would you order? What is the next thing you're going to do?
I'll go for... Can you hear me?
Yes, of course.
I'll go for a skeletal survey.
Very good.
To see other sides of the injury.
Very good.
We'll take a detailed history from the parent.
Okay, good. So you go for a skeletal survey. In England, it's different because everybody that comes to hospital, frequently, they are registered and then there's an alert on them. So when they go to any other hospital, there is an automatic alert on the registration system that this patient has been into hospital quite a few times, yeah? But in Pakistan, you need to make sure that you do a skeletal survey. And how will that help you?
Because that will show the different fractures at different sites, like multiple rib fractures and different stages of healing.
Very good. The key point is that they will be in different stages of healing, which means that parents either did not bring them to hospital or they did go to hospital multiple times for various views, okay? So that's good. I just wanted to bring this up to make you aware that non-accidental injury is a reality even in Pakistan. Actually, more so in Pakistan because nobody gets prosecuted, but here we do prosecute parents. So just remember that if a non-walking child comes with a fracture, then you must suspect non-accidental injury, especially in the exam. You must show your knowledge that you know about non-accidental injury. Okay, good. Well done. Okay, so what sign are we showing here?
This is Gilazzi test.
Very good.
So see the limb length discrepancy, whether it is femoral shortening or tibial shortening.
Okay.
The clinical picture, it's femoral shortening because
both the ankles are at the same place, isn't it? So the heels are same place. So therefore, when the heels are at the same place, then the femur is shorted, isn't it? Like, yeah? What is that? Is the differential diagnosis of?
So in a child with positive Gilazzi test, there can be
you can't say positive or negative, like, okay? Just say that the X-ray or the Gilazzi cell is present here, which means that the leg is shorter. It's absent here or present here, okay? Don't use word negative or positive because it's not an electric charge here. So here, there is a Gilazzi sign, and if the heels are matching each other and the toes are matching in the front, we know that it is a problem in the femur, okay? So that shows you know what you're saying about. So what are the differential diagnoses is this? So what is that?
It's radiograph of pelvis of skeletally immature patient showing left-sided developed DDA.
Shows what, sorry? It's simple. Rocket science, it's a dislocated hip. It's a development of the hip.
Lot of noise in the background. So
yeah, guys, can you please, guys? Okay.
Oh my God. Ali जा रहे बोले जैसे आप आए मैं जा
Okay, I'm going to mute everybody.
चाय ले आओ, ले आओ, चाय ले आओ, चाय ले आओ यार, चाय ले आओ।
Good smelling.
तुम जा रहे हो।
Okay, just give me a second. Yeah.
तो वीके
Hour में क्या है?
Over में एक
can
मिनट
mute-
है।
No idea how to
mute the mic.
फीमेल का।
Okay.
वो ऊपर शिफ्ट हुआ है
अलीम हम चक्कर लगा के आते हैं।
So, Shabazz, I'm going to mute everybody and then you unmute yourself. Okay.
Ji. So this is radiograph for a skeletally mature patient of pelvis showing left-sided DDH. That is classification is Jones 4.
Okay, so this is a 10-year-old child who was missed and is now presented in the clinic at the age of 10. So what are you going to do for this person?
So I'll assess clinically about the what the symptoms patient is having. If the patient is having pain or there is.
It doesn't matter whether the patient has pain or not. Your X-rays tell you that it's not normal, isn't it? So you won't go for pain. You have to do something to push it back into the socket. You can't just leave him like that. Okay, so at the age of 10, what would you do for this particular person as an investigation to help you that you can plan something for him?
We said at the age of 10, we will do the femoral shortening osteotomy. Then we
So let Shabazz have a go. We'll all discuss it in a minute. Let him have a go. When we finish, then we'll come back to you. Yeah? So this is an exam scenario where in exam, one person is allowed a chance to learn. We'll all join in. We'll do everything, but let him speak and see what he says. Yeah. Okay. So Shabazz, back to you again.
At the age of 10 years, the patient has got neglected DDH. So the book says.
Yeah. So my question was, listen to what my question was. My question was, what investigation will you do to help you plan for management of this patient? So what do you do? Have you ever seen one of these patients in the clinic?
What?
Have you seen a patient like this in the clinic?
Hear you.
Can you hear me?
There is some problem in the internet. I think there's some disturbance in the voice. What in the clinic?
So when you're in the clinic, what investigation do you do if somebody comes in with a picture like that? A child is 10 years old. His parents have brought you. Have you been in the pediatric clinic or anything like that? No?
Yes.
What would you do?
So the issue would be viability of the head, first thing, and the CT scan to see the anatomy of the acetabulum.
Okay, good. So you want to make sure that there is no pulvinar in the acetabulum and there is no shallow acetabulum before you do anything. Okay.
Yeah.
Then what's the next thing you will do? You will take the patient to theatre and you will do an EUA, an arthrogram under anesthesia. So you will see if you can reduce the hip into the socket by abducting it. Okay. So if you can abduct it and reduce it into the socket, then you need to do a varus osteotomy of the femur. Okay. If you can reduce it, but the shelf or the top or the cover is not there, then you do a pelvic osteotomy, and sometimes you may have to do both. So before you decide what you want to do, you want to scan the femoral head to see if it's normal. You need to do a ultrasound or even a MRI scan, which is difficult to do an MRI scan of a child, but an ultrasound to see if there is anything in the socket and is it good enough. How would you know that the acetabulum is working? Is there any ways of making lines in here to tell you if it's working?
So I can calculate acetabular index.
Very good. What is that?
So I pass a alveolar inner line and another line just along
so if you draw a line where the acetabulum the horizontal line, an H line or a Helling-Bayes line. Okay. So if you draw that, and then what's the other line you draw?
Okay. Then another line along the lateral edge of the acetabulum, superior lateral edge of the acetabulum.
Okay, from here you mean. All that is going to tell you whether it's in one of the 4 quadrants. This is obviously in the outer quadrant, so it is dislocated anyway. So that's not going to help you, isn't it? So what's a center edge angle?
That's one line.
It is difficult. I know it's difficult. I want you to struggle now so you don't struggle in the exam. Okay, so you learn today and then you don't do it in the exam. So go and tell me what you see.
So central edge angle shows the coverage of the acetabulum. So it's angle made by one line from the center of the femoral head and another line touching the edge of the acetabulum.
Okay, so what you're going to do is reduce this in theater under anesthesia while the patient is asleep by an EUA, and then you take a picture and you draw this H line and the center edge line, and which will tell you whether you need to do an vestibular osteotomy or not. Okay, this is how you plan these patients before. So if you can reduce this patient in abduction, what surgery are you going to do?
So according to lateral test of stability, if the hip is stable in abduction, that means the patient needs varus osteotomy.
You can do that. Before varus osteotomy, can you do anything else? What's a broomstick caster? You know what a broomstick caster is? A broomstick cast or a broom? You know what that is?
Yes, if the abduction cast that was mostly used in patients with Perthes disease to contain the femoral head.
So if you can reduce this patient easily in abduction, you don't need to do any surgeries to begin with. You can actually use one of those hip spiker with a broomstick to keep the legs in abduction. So we do that quite often here, very commonly, and up to the age of 10, you can do that. Okay? So what about if the patient cannot be reduced into the socket, then you can do either a varus osteotomy or an vestibular osteotomy or a combination of both. Okay? So these are the principles of managing people who come in late. If they come in early, the easiest thing for them is to put them in an abduction brace like, okay? So how will you diagnose this, or how is there a system that you can develop to see these patients that they don't get to the age of 10 before you see them? Is there a way of doing that?
So initially, after birth, there is clinical examination. There are tests that is called Barlow and Ortalny.
Good, yeah. So you can clinically check every child that is born the next day. Is that right? That's a screening test.
Yeah.
So once you've screened them, and what's Ortolani and what's Barlow? Tell me, what is it?
So Ortolani is a test of stability in which you aim to dislocate the knee, dislocate the hip, and in Barlow, in Ortolani you try to relocate the head, and Barlow
So O is out. So Ortolani, the head is already out. Okay, remember that. Yeah. So if Ortolani is out and Barlow must be in that you want to put out. So if you have a patient whose head is out, then you do a Barlow to see if you can reduce it. But this patient is already dysplastic. But if the patient is already in the socket and you want to dislocate it, that's called a Barlow's test. Okay, so you do a Barlow's test to make an Ortolani's test to bring it back in. Okay, so if you see a child on the day of birth or the next day that he has a clicky hip or a positive Barlow's test, what are you going to do with that patient?
So if the Barlow's test is positive and Ortolani test is also positive, then I'll go for dynamic ultrasound.
Right about Ortolani. All Ortolani tells you that you can put it back in, like, but Barlow means the joint was in the hip and you've taken it out and you've brought it back in. So you can say Ortolani, Barlowni, both, but don't use the word positive again. So what will you do with these patients?
I'll go for ultrasound examination of the hip.
When?
Dynamic ultrasound. At 6 weeks.
When, sorry? So what will happen until 6 weeks?
Most of the hips which are unstable at
birth,
they become stable at 6 weeks period. So again, you have to check the stability at 6 weeks.
Yeah, but what happens in between from 0 weeks to 6 weeks? You can't just leave those childs alone. You have to do something.
If the patient has got Barlow's positive hip, then you have to apply Paulik harness.
Yes. So if you have a child who's got a clicky hip, or he has got evidence of an instability, or you can do a Barlow's on them, you do double nappies for them for the first 2 weeks. Okay, you give them double nappies. Then at 2 weeks, you will examine them again. If they're still clicky, you will organize an ultrasound for them and organize to see what the ultrasound shows. If the ultrasound shows that they are contained, but they are unstable, you then organize Paulik harness. The Paulik harness is not given on the first day. It is given at 2 to 4 weeks, as you say. So you give them double nappies first, and then you give them an ultrasound appointment in 2 weeks' time. If the ultrasound is normal, you continue with the double nappies. If the ultrasound is abnormal, then you organize for a Pavlik harness. Okay, are we clear on that? So exam में जब पूछेगा dislocated hip, तो आप जवाब उसको ठीक देंगे ना. उसको यही कहेंगे कि I will examine the patient, and if the patient's hip is clicking or dislocating, I will give the patient a double nappy, review the patient in 2 to 4 weeks time, organize an ultrasound. And once I've organized an ultrasound, I will then ask to see what it looks like. I may continue with the double nappies or organize for a Pavlik hazard. Pavlik hazard का नुकसान क्या है?
Monitor.
Femoral nerve palsy.
We have to monitor the patient daily.
It's not monitoring. A pelvic harness अगर आपने सही नहीं लगाया ना, तो head का जो ना आपने pressure ज़्यादा increase कर देना है. You must know the complication of pelvic harness if you're talking about pelvic harness. Okay. Okay. Good. Okay. I've got all the difficult ones for you today, Shahbaz, so you will learn.
Okay, I am here. No issue.
Well, I am struggling too because pediatrics is not my specialty. So I had to learn today for you guys to have a practice. I had to go and read.
So this is radiograph of leg of a skeletal immature patient showing anterolateral bowing of the tibia.
Good, very good, yeah.
I cannot see the knee clearly, whether the knee is reduced or not.
But the knee looks all right in the joint, isn't it?
Yes, but there is shadow.
So how many types of bowing do you know?
So there is anterolateral bowing, there is anteromedial bowing, and there is posterior medial bowing.
So which one is physiological?
Mostly the posterior medial is physiological, but we have to assess again the distal tibial fasciitis because it's
okay, good. So this is an anterior lateral bowing, isn't it? So if this is an anterior lateral bowing, what disease is related to this particular type?
Congenital pseudoarthrosis tibia is related to this anterolateral bowing. So we have to monitor the patient for fractures and keep.
Yeah. But this is neurofibromatosis, isn't it? Like these are the type of bowing you will see in neurofibromatosis. The pseudoarthrosis will be a medial bowing, not a posterior lateral bowing, isn't it? I just want to bring this so that you guys can look at the X-ray and see if you can remember this. What's happening here? Weird and wonderful, yeah.
Yes. So this is a radiograph of skeletally immature patient showing.
So do you know what this is? Do you know what? Sorry, what this is? What's this?
This is called endogram.
What? Sorry. So we are trying to look at the length, isn't it? So this is what we're doing is a weight bearing standing to look at length. Right, so that's the key in it. So the first thing you need to see is look at the size of the head here and look at the size of the head here. Is there a difference? Yes. Yes. So then look at the leg femur and look at the length of the femur. Right. So the problem is mostly in the femur. Right, although the hip isn't joined, but the femur is shortened, and you can also see that there is some rotational element in the tibia. There is something missing. Is there something missing? Yeah, so it's called a fibular hemimelia, and this is a congenital shortening of the femur. Yeah. Okay. Is what? Sorry, you gone far up the mic. I can't hear you now. So what is it then? So if somebody shows you an X-ray like this, you will say that the femoral head is smaller than the other side, the femur is shorter than the other side, and the fibula is missing. So this is a congenital fibular hemimelia, yeah?
Okay.
Okay. Should we make it easier now?
So this is duplication of thumb.
Keep going, yeah? This is duplication, yeah, correct? Duplication of what?
Duplication of the thumb.
So it's duplication of thumb. How do you get duplication of thumb? There is a classification which helps you for thumbs. It's called Vassell's classification. Do you remember that?
Yes,
Have you read it?
I read that. I can't recall now.
Okay, so you basically have problems of growth. Okay, so you can have a bifid distal phalanx, you can have a duplicated distal phalanx,
Yeah.
you can have a bifid proximal phalanx, and you can have a duplicated proximal phalanx. Okay, so what would you do next? Very simple. You will organize for an X-ray. Yeah. So you've organized for an X-ray. What is the X-ray showing you? So there's duplication of the proximal phalanx here, isn't it? Yeah. There's no bifid picture, but it's just duplication. So that's what has happened is that the proximal phalanx has duplicated and has grown into a congenital extra digit. Isn't it? So there is a classification with these. There's a failure of differentiation, failure of segmentation, overgrowth, undergrowth, and multiplication. Yeah. So what would you do in this case if this patient was your patient?
So I'll assess the function of the thumb.
So both thumbs are working.
Both the thumbs are working. Then
so your option on exam answer is if there is no contraindication to surgery, the patient and family wants the operation to be done. My preferred procedure would be to see if the patient has got functional anomaly or abnormality. Yeah? So this patient has got a normal functioning thumb. My option would be to leave it alone. It's only a cosmetic deformity. Okay. However, if the family insists to have something done, I will take one of the thumb off. The one that is smaller and less functioning is the one I will take. Okay. However, whatever I do, I will keep the nerve and the artery for the thumb from the duplicated one also, because I don't want to lose that. Otherwise, if I do that, they will have phantom thumb and phantom finger features. Okay.
yes.
Oh, this is my favorite topic actually. Yeah. Have you given up, Shehbaz? Yeah.
No, Shehbaz is not given up. I have to connect the charger with my laptop. Just give me a few seconds.
Okay, just give me a second till somebody rang my bell. I want to see who's around here. Good. So should we let Shehbaz go while he's connecting? Does anybody else want to play? So I know Shehbaz, you've had a difficult day. Let's get somebody else to play. Yeah. Does anybody else want to play?
I can add then.
You can do this. You want to play with this?
Sir, did you hear me?
Yeah, I can hear you, but it's very low. Just give me a second. Let me get the sound a bit higher. Just give me a second. Yeah.
Here comes the diagnosis.
Yeah, because I've told you. For some reason I can't get my volume better. It's better now, yeah, okay. Can you see the picture now?
Yes, sir.
What is it? Go on then.
The diagnosis, the achondroplasia picture. You can go back.
No, so I'm not interested in the diagnosis. When you see this child, how will you examine him in the clinic? What is the first thing you will do? You have to confirm and prove that he is a dwarf, isn't it? So what is the definition of a dwarf? Do you know anything about limb span and height? Do you know what that means? Yes, no? So you can't be quiet, Shehbaz. You have to say something. Do you remember reading about limb span, height, all that kind of stuff? Okay, so I will show you this. So when you have a person in examination or in the clinics, you have to measure the arm span and you have to measure the length from heel to head. So normally it is normal, equal, okay? And the umbilicus is in the middle of the body. So you have to measure these angles and then you have to say that this is dwarf or not dwarf, okay? So you can say that the person is proportionate because his umbilicus is in the middle and arm length and height length match. If he is disproportionate, either the arms are longer or the chest is longer, okay? You have either a short trunk or a short limb. And then you have asymmetry where they're, when you have congenital hemiphilia and not the femur not growing up. The first thing you need to see as a dwarf is you need to measure whether this person is proportionate or disproportionate, okay? So you measure arm span and height. And the arm span should be equal to the height. So if it's not equal, then he is a dwarf. And then you have to decide whether this is a proportionate or a disproportionate dwarf. That will tell you. So if the umbilicus is in the middle of the height, then the patient is proportionate. If the umbilicus is not in the middle of the height, then it's a disproportionate dwarf where the limbs are bigger or the chest is bigger. You can see this. Some people have broader, longer legs and some people have shorter legs. Okay, do you understand that bit? Okay, so now going back to this patient, what do you think this patient has got? Achondroplasia. So he's a dwarf. Is he proportionate or disproportionate?
Disproportionate, Ivan.
Why? So you see the umbilicus in this patient. The umbilicus is not in the middle of the body, okay? So he's disproportionate because his limbs are smaller than compared to, so his chest is normal and his head is normal, but the limbs are shorter. So he's a disproportionate dwarf. So there's not many disproportionate dwarfs. The most common disproportionate dwarf is achondroplasia. Okay, so what do you see in achondroplasia? Then what is the classical features of achondroplasia?
They've got short limb height.
Good.
They've got trident hands.
Very good.
They've got frontal bossing. They've got short necks.
Good. There's problems with their spines.
They've got kyphosis.
Yes. So, I was asked this question in my exam a long time ago. That's a century ago. I was on my FRCS orthopedic exam. I was asked that if you are an Olympic doctor, in looking for disabled Olympics, right, what would you recommend for an achondroplasia person to have before you can allow him to have go and play the sports?
Because they've got high incidence of stenosis. So
what a high incidence of?
Stenosis, spinal stenosis.
Yes, very good. So what do you do?
So you have to get the X-rays.
Yes, so they all have to have X-rays before they can participate in the sport because you want to make sure that they don't have problems with the neck when they do the sports. Okay, so you know all your stuff. I don't know why you're getting worried about this. So you just need to.
I got some issue with the sound. So okay. in bits there is miscommunication. I can't hear you.
Okay, that's okay. So remember this now. You need to know whether it's proportionate or disproportionate. You need to know whether the center of the body is where the center is. You need to understand these things: proportionate, disproportionate, short lip, short trunk, or asymmetry. Okay, three different things you learn from this. Okay, so what you just said.
Excuse me, sir.
So yeah.
Sir, can you please repeat when to label that case of dwarfism you initially mentioned, sir? Can you repeat, please?
Yes, you were late.
Sorry.
So what you need to do is when you look at a dwarf person, first thing you need to do is measure their arm span to their height. They are both equal. So in a normal person, the arm span is equal to the height. Okay? So if they are not equal, then they are small. So you need to now know whether they are proportionately small or disproportionately small. So if you have problems with thyroid or pituitary, then they will be proportionate, but they will be either small or tall, right? But if you have got a congenital or genetic deformity, then they will be disproportionate. Either they will have short limbs or they will have a short chest. Which condition would you know whether you have longer limbs but a short body? Which congenital problem do you know?
Marfan syndrome.
Very good.
Marfan.
So who said that?
I did, sir.
I don't know. Tell me what, I can't see.
Salman sir.
Very good. Well done. Yeah, brownie points for that. Yeah. So Marfan syndrome will have long limbs but short chest. And so this is okay. So this is what they have. They're disproportionate. They're this chest and body is normal. That the umbilicus is nearly normal, but they have short limbs. They always have flexed elbows because their limbs end up with fixed elbows. All have high forces. They all have a trident hand. What's a trident hand? Whose computer is making noises?
I don't know, there's disturbance. Yeah.
Can you always mute and let Shabazz talk? This is his last. I have become more here. Okay, so try to.
When the space between middle finger and ring finger is smooth, so they've got widened space.
No, what they grow in 3 pairs of digits, and mostly as they grow older, they become normal. But they have 3 pairs of finger growth with gaps. They all have short, broad heads. They have a bust head and a short, sort of a very firm kind of nose. They have a protuberant jaw. Majority of them. Okay, so this is. Want to give up? Anybody else want to play? You've had good, well done. I mean, it's difficult questions they've asked you, but I did tell you that you need to be prepared for your. And all of you don't mute except who else is play. Can you also mute?
This noise is coming. Yes, it's fine now, I think.
Okay, good. So, do you want to play Satish or somebody else?
Yes, sir. I want to play.
Fine. Okay, good. Have a look at this X-ray now. Sorry, now my computer's not working. There you go.
No, we can't see the X-ray
At all. Okay.
We are stuck at the achondrope laser slide.
Okay. Now can you see it?
No, we don't.
Give me a second.
I think close the presentation and start again. I think that will solve it.
You see it now?
No.
No, sir. We can't see the screen.
Okay, just give me a minute, yeah? I'll come back in a minute, yeah?
Okay, sir.
Okay. Yes.
You see now, yeah?
Yes.
Yes, sir. We can see the screen now.
Okay, now tell me what this is.
Me or Satish?
Satish. You've had
yes,
enough, Baz. You've done well. You've had enough.
Thank you.
Okay. I can see the this is a CT scan, axial section.
Yeah.
Of a bilateral hind foot, and I can appreciate collision between the two tarsal bones that are calcaneum and navicular.
So in the exam, you need to be more prominent. You don't say that when you're a consultant to your registrar. You will say, this is a CT scan showing tarsal collision on both sides. Okay? By saying that, it shows you're confident, you know what you're saying, and you have actually seen what you want to say. Like, okay? So this is a tarsal collision of a. So what types of tarsal collision do you know?
So there are two types based on anatomical location. These are calcaneo-navicular.
Yeah.
And a talocalcaneal collision.
Okay. So which one is this?
This looks like a calcano navicular, sir. But I need more views to confirm that.
Don't have more views, unfortunately. These all I've got, yeah. So I have to read all these
Look
things last night, you know.
Okay, sir. I think
Okay,
look
so-
like calcano navicular collision.
Okay, so what types do you know? There's a fibrous type, cartilaginous type, and osseous type, isn't it?
Yes, there are three types: fibrous, cartilaginous, and osseous.
So this is osseous, yeah?
Yeah, right side look to be osseous,
Yeah.
and left side I am not sure whether it is a collision or not.
So how would you know that this is a fibrous coalition or not?
So on the X-rays, I can see a gap, while on the CT scan, I can see some collision.
Okay. So in clinical examination, how will you assess that this patient has got, so the patient has got a painful heel pain, like I said, what test would you do to tell you that this patient may or may not have a osseous tarsal collision? I know you can do a CT scan, but before the CT scan in the clinic, what would you do?
Yes, patient may have a restriction of the movement over the subtalar joint. These are inversion and eversion restrictions.
Yeah.
Also, patient can have a rigid flat foot.
Yeah, so if the flat foot is not passively correctable, then there is a high chance that this is an osseous tarsal collision. If the flat foot is passively correctable, i.e. if you put a stand on your toes, you have a heel raise test, they will correct the tarsal, the flat footness, and therefore you can be sure that it is not an osseous type, but you do a CT scan to confirm it. So everybody's leaving. I had 19 people and now everybody's gone. So maybe we are too difficult to, isn't it? So what is this?
This clinical picture is showing Goward sign.
Okay, very good. What is Goward sign?
Goward sign, it is a sign in which we ask the patient to stand up from the ground. We label the sign as positive. When
don't say positive or negative in the exam, please, Satish. Yeah, just say that the sign is present or absent. I'm not sure.
It is present in muscular dystrophy, like Duchenne and Becker's muscular dystrophy.
So what is this patient doing? You can see this guy is trying to describe what the patient is doing. So he can't get up because he is weak. So what is he doing?
This patient is using his hands to extend and lock the knees, and then he stands.
So he's using his hands to help his muscle to lock the knee so he can get up. Like that's a Goward sign, yeah?
Yeah.
Very good, yeah? So how do you describe clinically a person who has got muscular dystrophies?
So these patients have a history of progressive muscular weakness.
Yeah.
Usually these patients are young children ranging between 6 to 10 years of age. They complain of proximal myopathy that is progressive.
Okay. So the hips are the extensors are the first bit that are involved in these patients. You know that, yeah? So the hips are the first, yes, okay. So what blood test would you do to give you a diagnosis that this patient may or may not have a muscular dystrophy?
Yes, I want to have the levels of creatine and phosphokinase levels.
Yeah.
And these are usually elevated in these cases.
Very good. What else can you do?
I can do as the muscle biopsy to confirm a diagnosis.
Exceptional. That's very good. Yeah. So you can do blood test and do a muscle biopsy to confirm these. There are only two that people normally see. There are Duchenne's and the Becker's type, isn't it? There are various others, but those are not so common. But good. So this is what you can be shown on the exam: a slide of Duchenne of Goward's test, and then everybody talks about it, and they go from there. Okay.
Right.
About this. This is a 10-year-old. He's a 10-year-old overweight child who's come to see you in the clinic, and he's limping, he's painful, and he's unable to weight bear.
Okay, this is the X-ray pelvis AP view of skeletally immature child, which shows a right-sided slip of the femoral capital epiphysis.
Very good.
Yes.
How do you know it's
on the yes, I can appreciate.
So what test will you do? By drawing a line or something? What do you do?
Yes, I want to draw the Achillean line on the AP view, which runs along the upper aspect of the femoral neck and crosses through the physis.
So from here to here, yeah?
Yes, while in this case it looks that it will cross above the epiphysis.
Yes. So you said Klein line. Klein is an American thing. I come from England, so we call it the Chant line. But it's the same thing. You do a Klein line or a Chant line, yeah? So you draw a straight line, and if it's missing it, something's wrong. So I said something very important in history. The patient is not weight-bearing at all. What does that mean?
If patient is not weight-bearing, means probably it is an acute slip, or we can say it is an unstable slip.
Okay, so there is a name to this. What is it called? Do you know anything about Loder's classification?
Yes, sir. There are Loder classification, which classifies these slips into stable and unstable slips.
Exactly. So you told me it was an unstable slip, and the reason is it's a Loder non-weight bearer because you can't weight bear it, so it's an unstable slip. So what can you do here? What will you do for this patient?
Yes, I'll start with a detailed history and examination.
Okay.
I want to evaluate for any hormonal issue in this patient, especially hypothyroidism.
Very good, yeah.
Yes, after confirming all this, I need another frog lateral view in this patient to confirm my diagnosis.
But the patient is unstable, he's painful, and he's got a slip. Why do you want to do a frog lateral view?
Okay, so in acute slip, I can't do.
Exactly.
So I will.
You know, you just said. देखो किताब वाली बातें नहीं करनी है इम्तिहान में जो चीज़ normal होती है ना जैसे आप clinic चल जाते हो ना when you work in a clinic. So if you have an acute slip and you have a picture like this, you don't want to do a frog lateral, isn't it? Because you're going to make it worse.
Okay, right, got it.
So you have enough evidence here that this patient has got a Sufi, yeah?
Right, sir.
Okay, so what will you do for this patient? You said you will do hormonal lysis, you will take a family history, and you want to make sure that he's not bilateral. How can you assess this to have bilateral problem?
So I will, yes. I'll draw the lines on the left hip as well.
Yeah, so the left hip is normal. They're normal.
Yeah, yes. On this section looks to be a normal, I think.
Yes. So what will you do for this patient?
I'll plan for a surgery in this patient that is in situ fixation with a single or multiple cannulated screws.
Just one screw, yeah? One screw. How would you know that the screw has pierced the joint?
I will start my screw point from anterior going towards posterior.
Listen to the question. You put a screw in, it looks very good. How do you know that this screw has not gone through the joint?
Or I'll do the perioperative range of motion to see any impingement.
The what you call them, the socket even more with your screw, yeah, by moving it all around.
I can get a post-op CT scanning in case I am in doubt.
Scanning, he's off the table then, isn't it? What can you do on the table to make sure that the screw is not in the joint? वो जो screw होता है ना cannulated होता है उसमें आप contrast inject करेंगे ना तो अगर वो joint में leak होता है तो screw is in the joint अगर joint में leak नहीं होता है तो इसका मतलब है screw is not in the joint. Very simple thing.
Okay, right. I actually haven't seen this, sir.
But if you examine this patient, you will scrape the whole of the joint, isn't it? And if you leave it for CT scan, then you have to bring him again. उसका जो screw है ना उसके अंदर contrast inject करें और उसकी arthrogram ले after you finish your procedure. Then you know whether you're in the joint or not. All you have to do is unscrew it a few times and you're out of the joint if it's in the joint. ठीक है?
Okay, sir. I got it. Thanks.
Very good. Okay, so this is a Sufi. You have to always do them in situ. When is it that you do an osteotomy in these patients?
When we fix these SCFE, later on patient when develops a deformity, we can plan for a corrective osteotomy later on, sir.
So there's a lot of people in Japan that are doing, some fish and done osteotomies and all the kind of osteotomies for these patients. So what patient will you need to have an acute osteotomy?
Sir, when the Southwick angle is more than 60, means there is severe slip. I can plan for a Dunstan osteotomy and a nautical reduction.
Okay. So आप लोग का सारे surgeon सारे काम करते हैं उधर. If you see this patient and you're not a pediatric surgeon, you will still plan to do an osteotomy?
No, sir. I will plan to do an in situ fixation of this slip.
Okay.
And later on, if the patient develops deformity, I will plan for deformity correction later on.
Okay, so what you can say in the exam is, in my field, I will do a slip fixation in situ. However, if I feel that this is a Southwick 60 degrees or more, I will ask my pediatric colleague to help me out. You can say this in the exam.
Right, sir.
The examiner होता है वो बहुत ही बेवकूफ आदमी होता है वो फिर आपको कहेगा आप pediatric surgeon है what are you going to do? Lekin you have to tell them that this is a super specialist job and you have to send the patient to a pediatric unit. Like, okay, agar aap nahi bata to they take it wrong, but if you tell them, they will still tell you are the specialist, now do what you want to do with this guy. Okay. So this is a child and you can't get a child wrong. If you get a child wrong, it is for life. Okay, so very good.
Yeah.
Very good. So what about this one? This is an X-ray of a hand of I think it's a 20-year-old that came to clinic with a painful little finger.
Yes, this is a X-ray hand PA view of a skeletally mature patient.
Yes.
I can see a small lytic lesion in the proximal phalanx of the little finger.
Very good.
The lesion is located in the epiphyseal metaphyseal location.
Okay.
That is eccentric, lytic with no any permeation and no significant bony reaction.
Okay, so you can say there is no permeation, there is no periosteal reaction. It looks very, very benign to me. Okay?
Yeah.
So what do you think it is?
Probably it is a benign enchondroma.
Very good. This is the commonest site to have them, So how do you treat these?
And when they are symptomatic, we can treat this with a simple curettage and possible bone grafting.
Okay, so if it's not symptomatic, you leave them alone. If they're symptomatic, they've probably broken, they're fractured. You can see there's some break in there. When they fracture, they bleed, and when you bleed, they actually heal and close it up. So if there is symptomatic and it's an incidental finding, leave them alone. If they're symptomatic, observe them and see what happens. Most of them will heal from the fracture and close it. If they don't, you can either put some sort of steroid in them or cement in them or some sort of bone graft into them. Yeah, but they are benign conditions. You need to understand no periosteal reaction. Permeation is very clean and clear. They're well demarcated and they're not destructive. Therefore, it looks like a benign condition. Okay, so that's what you have to say in the X-rays when you see them. Okay.
Right, sir.
I think we've finished with pediatrics.
Sorry.
Just give me a second.
Excuse me, sir.
Yes.
Sir, I just want to.
I can't hear you now. Sorry. Go on. I can't hear you. Sorry.
Hello, sir. Can you hear me, sir?
Yes, yes.
Sir, I just want to ask. You were saying that you can inject steroids into enchondroma.
Yes.
Is it so, sir?
Yes, there is no evidence to support it, but when you're doing there and you have nothing else to do, you can. I mean, I have never injected it purely because I'm not a pediatric surgeon. I don't see many of these or the enchondromas. But what is happening in this country is people are putting PRPs into them and people are putting cement into them. So there is no evidence to support whatever you treat for them. Okay. One final one, Satish. If you see this one, what is this?
Yep. Yes, sir. So this is a child in which I can appreciate that the neck is tilted towards the left side, and it is rotated on the right side.
Okay. So what do you think it is?
I think it is a congenital muscular torticollis.
Very good. What is the treatment for these?
Treatment for these is initially we advise the affected side sternocleidomastoid muscle, and usually most of the children get better with stretching exercises. If not,
physiotherapy is the mainstay. What you have to do is one thing before you do physiotherapy. There's one thing you have to do.
Yes, sir. I want to have an X-ray of the cervical spine to rule out the subluxation.
Yes, if you exclude there is no subluxation and it's a congenital torticollis, you want to do some sort of ultrasound or imaging to tell you whether there is contracture of the sternocleidomastoid or is it just stretching will help. And if you know that it's not slipped and there's no contracture, you can get the physios to help you. There are a lot of operations for sternocleidomastoid stretching, but that's what it is here.
Right.
Let's do this. What's this? Cerebral palsy. Okay.
This is a case of cerebral palsy, yeah.
So what type of cerebral palsy patients do you know?
So there are different classifications.
Okay.
One are anatomical classification.
Okay.
in which these can be diplegic, these can be quadriplegic, or these can be hemiplegic.
Okay. So depending on the ambulation of the limbs, you can classify them. What other classification do you know, which is what we use here and being most common?
Yes, most common classification, the GMFC classification,
Yeah.
which divides these patients into 5 major groups.
Yeah, listening.
Yes, group 1 patients are mobile patients, they can walk unsupported.
Good.
And group 2 patients can walk, but they have a difficulty in walking on uneven surfaces.
Okay.
Okay, group 3 patients usually need some support like prosthesis to walk. And group 4 patients.
There are non-ambulators. The non-ambulators are either community ambulators or
Okay.
need orthotics to hold them, isn't it? Like, yeah. So that's how you need to make it simple for yourself. So what is it?
Right.
He's ambulating, but he's using a wheelchair to move around, isn't it? So the next question that you get asked in cerebral palsy is gait. So what do you understand by gait?
In cerebral palsy, there are different types of gait. We can see true equinus, we can see apparent equinus, we can see crouched gait, and we can see jumped gait in these patients.
So describe gait. What is gait?
It is a ability or a potential of a patient to walk, sir.
Okay, so I mean, it's what I mean. You need to tell me more, isn't it? There's a lot more to gait than just saying able to walk, like, isn't it? But yeah, it's correct. What you said is correct. But you need to tell me more.
Sorry, sir. I do not have exact definition of the gait, sir.
So it is the mobility from going from one place to the other, isn't it? And it is of 2 components. Now, do you get it? There's this.
Yes, I got it.
Okay, good. Yeah.
Yeah, there are 2 components. There are stance and swing phases.
Okay. So how long is the stance phase and how long is the swing phase?
Yeah, stance phase comprises of 60% of gait cycle.
Yeah.
While the swing phase comprises of 40%.
Good. So the time you're on the ground is 60%, and the time you're off the ground is 40%, isn't it? So
yes, sir.
So go on, start with the swing phase. What is in the swing phase, or do you want to start with the contact phase? So there are phases to these phases. What is that?
Yeah. Yes. In the stance phase, there are 4 to 5 phases. That starts with a heel strike.
Yeah.
After that, there is a loading phase.
We can't use heel strike anymore because in a cerebral palsy patient, he will not have a heel strike, isn't it? Or if you have a Kayvis foot, he will not going to have a heel strike first. So what's the other word you want to use?
Initial contact, I will say.
You know everything, Space, but why do you say things to get yourself into trouble? Why do you start with heel strike? So if I was an examiner, you want to keep me asleep. You don't want to wake me up. You want to say things that I just suddenly wake up. So you said heel strike, and straight away I woke up. Otherwise, I was just going to relax and let you talk, like I said. So initial contact, very good. What else then?
Okay, initial contact. After that, there is a loading phase.
Yeah.
And after that, there is a mid-stance phase.
Okay.
And last phase is the toe-up or pre-swing phase.
What, sorry?
Last 4th one phase is the, I think, heel up, or we can say pre-swing phase.
Okay, so you can call that initial contact, loading phase, and then pre-swing phase, isn't it? Yeah. So then what?
Yes, sir.
And then?
After that, swing phase starts, which consists of 3 cycles. These are pre-swing, swing, and the last initial contact.
Okay. So when you put your foot down, what is the importance of the foot? I mean, how does it give you stability? What has to be present for you to have a stable stance phase?
For a stable stance phase, we need stability of quadriceps.
Good.
We need stability of gastrosoleus complex.
Okay.
We need a stable tibialis anterior.
Okay. So you can say there is a soft tissue phase to it and there is a bony phase to it, isn't it? So the hip needs to, for a stance phase, the hip needs to be extended, the knee from flexion to extension and locked into it, and then the foot put down. So what part of foot allows you to have stable gait?
Sorry, sir, can you repeat the question?
So what does the foot have to do for you to have a stable gait? Do you know what a tripod gait is?
I can't recall the tripod gait.
So the heel, the big toe and little toe are 3 bits that has to be stable for you to have a stable stance phase, yeah?
Okay, sir. Right.
So heel, big toe, and little toe. This is the principle of rheumatoid surgery also. When you're doing surgery on the feet, you have to make sure that the hind foot is stable so that there's a stable part at the back. Then you have to make sure your big toe is stable. So you do a lot of fusion and surgery around the big toe. And you also make sure your little toe is also putting it down. So for stability, you have to have a tripod gait or 3-point contact. Okay, and that's what's important for your gait also. In the gait, whatever your muscles do, your foot has to be flat and allow you to stabilize by having a 3-pod gait. You know, वो जो फिल्मों में देखते हो ना, जो खलास से मखलूक आते हैं, उनके सारे जाजों में 3 टांगे होती हैं. Put 3 feet because 3 feet is stable feet.
Yes, sir.
You don't have plugs, but in England, जो plug होते हैं ना, जो बड़े वाले, उसमें भी 3 pin लगे होते हैं क्योंकि 3 pins are stable. They don't fall off very quickly. Anyway, well done. Okay, so
Thank you, sir.
Let's go and have something easy. What is this? This is easy. This is very easy.
Yes.
Let's let everybody else apply. We are learning from each other, but I want people to speak. If you don't speak, you can't pass exam. Let somebody else have a go. Well done. Very good.
Oh, thank you very much.
Anybody wants to have a go? Yeah, I've picked a very easy one. So why you guys are worried? This is an easy one.
So this is the intoning of the child.
So who's speaking? Tell me first.
Salman, sir.
Okay, very good, Salman. I want to show you a picture. There you go. So what's this?
Right, sir. So this is the bilateral intoning of the toe.
Okay.
So
how do you examine these?
Sir, by the Staheli's rotation profile, sir.
Very good. So what's a Staheli's rotation profile? Very good. I'm impressed.
Sir,
very good.
We see the components, sir, by the first the gait. We see in the linear line if the toes, the position of the toes in the gait. If
so
it's
the Staheli profile starts with a hip, isn't it? You have a hip, and then you have a knee, and then you have an ankle, and you have toes. So what happens?
Yes, sir. There are 4 components.
Yeah. First of all, you do is you make them walk in a straight line. Yeah.
Yes, sir.
And you look at how much internal rotation and external rotation they have. So when they do a straight line test, then you want to isolate where they are, whether it's in the hip or the knee or the feet, isn't it? So how do you test the hip?
Sir, by testing the hip, sir, we see the patient will apply on the supine position, and we will
supine.
Rotate the hip.
Supine or prone? Yes. Prone. Yeah, prone position में डाल के. So extend the hip and flex the knee and see where the trochanter is. Okay, and you put your hand
right,
and make it parallel to the floor, and you to make sure that the foot is also vertical from the knee. Yeah. So then you rotate it and you see what position does it make it flat or parallel to the ground. Okay, this is for assessing the hip. Okay.
Right, sir.
So what about the knee?
Sir, we see this the thigh foot angle, sir.
Okay, how do you do that?
Sir, again, the patient is in prone. We flex the knee at 90 degrees. We see the plane of the foot and the plane of the thigh, sir.
Very good. So that is tell you whether the problem is at the hip or the knee, as in the tibia. So now you've got no problem in the hip and you've got no problem in the knee or the tibia. So how do you assess for the ankle?
Right. Sir, at the ankle, we will see at the foot, sir. Again, the patient is prone. We see the foot, the plantar aspect of the foot, and we see the forefoot and the hind foot, sir. If the second rib space is in line with the hind foot.
So you make a line parallel to the ankle, medial and lateral malleolus, and you have to have a perpendicular line that needs to go through the middle of the foot and make it neutral, isn't it?
Yes,
so
sir.
In-toeing, ex-toeing, or you have metatarsal adductors or something like that. Okay. So when somebody shows you one of these patients, you have to know your Staheli profile and you need to know how to do it. You make them walk on a line. If they're walking straight on a line, you don't need to do any test. If they're not walking straight on a line, then you have to know whether it's coming from the hip or below. So above the knee, below the knee, and below the ankle. These are the 3 things you need to make sure which one it is, and that will tell you where the problem is. So if somebody's got a problem in the tibia, okay, so you've got in-toeing and a tibia, what is the age that you will manage them non-operatively for?
Sir, usually at the age of 5 to 7, we will continually observe.
12.
Because at that time, it's physiologically. After that, we will continue to observe.
Yeah, up to 12 we observe. After 12 you have to correct them.
Okay.
Most of them correct up to the age of 12. I don't know where the age of 12 came from, but unfortunately that's written in the books. Like, okay. So what's this?
Right. Sir, this is the metatarsal adductus.
Okay.
of the
So
foot.
how do you know this is a metatarsal adductus?
Sir, again, we draw the imaginary line between the forefoot and the hindfoot.
Okay.
And we see where the line is intersecting.
That's very good. But in the exam, you will say, I will do the Staley profile of the patient if the patient is walking. If the patient is not walking, I will assess whether the hip's a problem, the knee's a problem, or the foot. Here, clearly, the foot is adducting towards to the big toe. Therefore, I think this is a metatarsus adductus. What else do you want to do now? The X-ray.
But again, I would like to examine, take the history. I would like to examine for associated anomalies. For
what do you get with the adductus? What do you get with the adductus? Metatarsal adductus.
Sir, torticollis.
Okay, like but you get dysplastic hips, isn't it? Like, you know, people who have got problems.
Dysplastic hip, yes.
Yeah. Yeah, what is this? It's totally unfair. I don't know what it is, yeah, but you can tell me what it is.
Sir, this is the congenital vertical talus.
Okay.
Here we can see, sir, there is the talus is almost perpendicular to the floor.
Okay.
And also the physical exam, the rocker bottom feet is, we can see.
Yeah, so what will you do with this patient? Very simple answer, if you think of it.
Sir, we will attempt to perform the reverse
pulsarity. God no, this is a child, you don't do any surgery. On the exam, you're going to say, I will refer this patient to a pediatric surgeon. This is what you have to say. You can't get out of this. Okay. I will refer this patient to a pediatric surgeon, especially Bhatti Saab ke paas bhej denge, ya kisi aur ke paas bhej denge. This is what you have to say in the exam. You have to get used to this. You can't treat everything. The examiner जो है वो आपको फिर जो है ना वो बात सुन के फिर कहेगा नहीं आप स्पेशलिस्ट हैं आप बताएंगे, लेकिन अगर आपने उसको नहीं बताया ना कि इसको स्पेशलिस्ट के पास भेजना है तो वो फिर खिंचाई शुरू हो जाती है. You have to say this, that this patient has to go and see a pediatric surgeon. Okay, you have to say this in the exam. Whether you do it in your real life or not, well, you should do it in your real life, because 2 साल के बच्चे के साथ जो करेंगे वो सारी जिंदगी आपको याद रखेगा. लेकिन you have to send them to a pediatric surgeon. You have to say this in the exam. So this is vertical talus. It's a complex problem. It may need plaster correction. It may need manipulation. It may need surgery. I don't have the experience. I will send this to a pediatric surgeon. That's what you say in the exam. However, if the exam comes back and says, oh, you are the pediatric surgeon, what are you going to do? Then you will say, I will tell you the principle of management of this patient. I have not actually seen or done anything with this patient. Now, principal management क्या है? Principle है कि इसकी physiotherapy कर सकते हैं, casting कर सकते हैं, लेकिन vertical talus में predominantly surgery जो है इसका role होता है. उसके बाद अगर आपने सर्जरी के प्रोसीजर्स भी आपको आते हैं तो now you're going into distinction style. But if you say first straight में मुझे आप कहना आपने सर्जरी करना है, straight away जाए मेरा तबीयत खराब हो जाएगी एग्जामिनर की, वो कहेगा यार इसको तो हम कहीं सर्जरी करने का बहुत ज्यादा शौक है.
I think, sir, you must said I was saying casting is first. I never said surgery.
I know, but you cannot say this.
But again, you are. I said it's
पहली बात यही करनी एग्जाम में कि जो है ना मरीज को मैंने पीडियाट्रिक स्पेशलिस्ट के पास भेजना है, जो भी.
Right, sir.
This is what you have to say in the exam, you know, irrespective of what the patient is. Let's go back to hands. I think, have we done enough of feet, isn't it? Okay, what is this? Did you see this, yeah?
Sorry, sir. Which patients are the femur fracture or the radius ulnar? Which?
No, I'm showing you a picture. This is the radius of femur fracture, isn't it? Tell me, whatever is on the screen. So this is a 2-year-old that came to A&E, had a fall, a witness fall, which means not an accidental injury, and he has got an X-ray of these. So there's shortening and there's overlap.
Yes, sir.
What would you do?
Sir, again, sir, I would ask the age of the patient, sir. How
I told you 2 years.
2 years, sir. Yeah. I would see, sir, it is the closed or open injury.
It's closed.
Then it is closed. Then, sir, I would like to, sir, reduce and apply a spica cast.
Okay,
And
you can do
gallows,
gallus
I
traction.
can apply gallows traction.
2 years gallus traction. कब तक इसको gallus traction में रखना है? Until what time?
I'm sorry, sir. I don't know the.
So you will put this patient in gallus traction for 6 weeks. That is what the books recommend. Yeah, जब तक gallus ना लगाए, जब तक जो है उसकी length और वो सब कुछ ठीक ना हो. Do you know what traction psychosis is?
No, sir. I'm sorry, not familiar.
So जो बच्चे होते हैं ना, कितने एक्टिव होते हैं, सारा टाइम उछल कूद करते हैं, भाग रहे होते हैं. अगर आप उसको बिस्तर में बांध के रख दें 6 हफ्ते के लिए, तो आपको क्या रिजल्ट होगा बच्चे का? वो तो पागल हो जाएगा ना.
Yes, sir.
Definitely. So what we do in our part of the world is we put them on gallus traction for 2 weeks until they're sticky enough. And when they're sticky enough, we do what you said. We would put them in a hip spica. Okay, so that they can be mobilized. The problem is maintaining the hip spica and management of it, but far better. But the treatment is also that you can put them in gallus traction for 6 weeks. Thoda sa bada ho gaya, so you can fix them by putting a plate on them or whatever you want to do it like that. But up to the age of 2 years, you can put them on gallows. Okay, let's go back to hands. So what is carpal tunnel syndrome? I will give you all these slides, no worries. I will give you once we finish, you can have them all. But tell me what is, wow, we don't have carpal tunnel syndrome, amazing. I think we have, but it's later. So what is carpal tunnel syndrome?
Sir, it is basically the compression of the median nerve during the carpal tunnel, sir.
So the median nerve is compromised, isn't it? Yeah.
Yes,
so what
sir.
symptoms will they present?
Sir, there will be, sir, the pain and
Carpal tunnel is the most
yeah,
important thing you can see. So what does carpal tunnel do? You have pins and needles in the distribution of the median nerve.
median nerve, yes.
Yeah, you wake up in the middle of the night from pins and needles and paresthesia. You have features of dropping things, and you have features of unable to hold and open jars. Is that right?
Yes, sir.
Okay, so why do they have pins and needles at nighttime that makes them to wake up?
Sir, because of the relaxation of the muscle, sir, it will cause more compression of the direct
compression. Cause more compression, sir जी. अगर relax होगा तो फिर compression कैसे बढ़ जाएगा? What is a Phelan test and what's a reverse Phelan test? Or what's a? So there are 2 tests for carpal tunnels. You know that, yeah?
Yes, sir.
What are the tests?
Sir, there is the direct compression test.
Yeah.
There is also the flexion, the Phelan's test, in which we flex the wrist and wait for 30 seconds.
Okay, so for a minute, not 30 seconds, yeah? And what does that do? You're tightening the compartment, isn't it? Or you tap it, right? Or you flex the wrist to make it. So what happens then? You're flexing the wrist, isn't it? So रात को बंदा जो है वो नींद से क्यों उठता है?
Sir, change of postures, flexion of the wrist.
So why do they do that? रात को, you know, the fetal position is when you were in your mom's tummy, you were all flexed at your hip, flexed at your knee, and flexed at your wrist. That was the fetal position. So when you go to sleep, you go into fetal position where everything is flexed. Because you're flexed, you're causing your own Phelan test. So therefore, they get a lot worse at night time. Okay, what is the management of carpal tunnel syndrome?
Sir, originally, again, sir, I would like to do the metabolic workup as well. And also for conservatively, I would like to apply the nighttime wrist brace.
Okay, so do you not want to confirm that this is carpal tunnel syndrome?
Sir, again, the physical examination and also the nerve conduction study, also monofilament test, I would like to.
So what's a nerve conduction study?
Sir, nerve conduction study, in which we assess the velocity of the impulses from proximal to distal side, sir.
Okay, and what does it show?
So it will see the increased latency of the amplitude and also the.
So पहली चीज क्या जाती है? जो sensory जो होता है ना, latency बढ़ जाता है, complex लंबा हो जाता है सारा का सारा, और फिर उसके बाद motor भी उसमें आना शुरू हो जाता है. So sensory nerve
Yes.
action potential, then delay of the complex, a bizarre complex, broader complex, and then motor action potential is also gone. These are all tests which you can do with the nerve conduction study. How many times do you get a nerve conduction test positive when you do a test?
Yes, sir, I don't know, sir.
So very rare. Only about 10% of times you will have a positive nerve conduction study. Why is that? Because when you are having your test, your hand is straight on the table, it's not doing anything, and you're just testing it, isn't it? So that's what not we do in life. In life, we're moving our hands, we're flexing it, we're extending it with various holding grips in there. So it does not mimic real life. All it does is a static test, which is not worth anything. But unfortunately, you have to do it. So this is a hand with a carpal tunnel syndrome. What can you see on this hand? This is one of my patients from my private practice, actually. So what can you see here?
Sir, yes, sir. I would like to see the comparative of the opposite hand, but in this hand I could see
This is your only
wasting of
picture I
the
have.
thenar
See,
imbalance.
there is thenar wasting. Can you see that? Yeah.
Yes, sir.
Okay.
Yes, I can see thenar.
So this patient came to see me, and he said that my hand sensation is altered, and I've got a lot of wasting in my hand. So I did not do a nerve conduction study, but I offered him an advice. And what advice do you think I told him? I told him you need an operation to get your nerve released. Why?
Sir, for sir, sir, can you relieve the pressure and there will be a better.
No, so it's all wasting there, and it's all got sensory loss, isn't it? So why do you want
Yes,
to
sir.
do an operation? So the reason I would like to have an operation here is to stop progression. If you don't release it, it will get worse. However, nerves don't like compression, age, and duration. So if this was a 95-year-old man, okay? So a 95-year-old man with symptoms from 2 years and compression, he's never going to recover back to normal. So before the operation or surgery, I told him that he's not going to come back to normal, but you need to have it done, because if you don't do it, we won't stop progression. You will end up losing all the function of the median nerve, okay? Okay, so I want over here. I don't know, something's happened to my slides. They've all gone mixed up, like, isn't it? Are we enough, or do you want to go? Do we have to do more, or do you want to have a break or come back again tomorrow? What do you guys want to do?
As you wish, sir.
Well, it's not my you know, I'm not doing anything. I'm just sitting here and having fun. You know, it's all up to you guys, like, isn't it? So hand.
Sir, I'm game.
Sorry?
Proceed, sir.
Yeah, okay. So what is Wartenberg phenomena? It's a hand condition.
Sir, when we try to adduct the fingers, what happens that the little finger will again abduct because of the ulnar nerve path.
Sorry?
So when we try to adduct our fingers,
Yeah.
the little finger will slightly abduct away from the.
Why?
Because of the weakness of the adductor digiti minimi.
Yeah, one of the nerves is being irritated, and that's what happens. It's called Wartenberg phenomena. It is basically because they're wearing tight watches on the hand, and people are doing racket sports, they end up with Wartenberg phenomena. What's this?
So Raynaud's phenomenon, sir.
Okay, what is Raynaud's phenomenon? So it's an orthopedic exam. Orthopedic exam में Raynaud's phenomena का patient को रखेगा उसमें आप it's common sense.
Nice, sir.
Yeah, but what is Raynaud's phenomenon? Now that you mentioned it, we can all revise it. Go on then.
Sir, it's basically the vasospasm of the arterioles during cold weather.
Okay. So you have spasms. This is called white hand syndrome. This is related to vibration injuries, where repeated work with vibration tools gives you white fingers and white hands. Okay, this is a condition where it is mostly vascular, but it is related to vibration around the wrist joint. Mostly people are using those drill tools in the roads to build. That's what it's called anyway. So this is another topic. So what is this? This is the mangled hand. How are you going to decide what to do with this? मैंने किसी और को नाराज कर दिया, वो भी छोड़ के चला गया। सलीम साहब लोग भाग रहे हैं। हैंड्स के वाइव और पीड्स में से लोगों को टेंशन हो रही है। कल को इम्तिहान देना होगा सबने। तैयारी तो अभी है, इसमें कोई ना बेइज्जती है ना कोई वो है। This is just basically revision with friends. So do you want to stop? सलीम साहब किसी और को पूछें?
As you wish, sir.
I mean, everybody needs to speak.
Yes, sir.
Who's talking now?
Yes, sir, I will describe these pictures.
I don't know who you are. Tell me who you are first.
Salim, sir. Salim Qureshi.
Oh, very good. Salim Saab, I can't see you, but I can see you're on my system anyway. Nobody wants to show me that picture anyway. Go on, what is this, Salim Saab?
Sir, this clinical photo demonstrates that there is a severe crash injury to the hand and as well as the forearm. So, according to the MES criteria, so we can describe that initially the injury, whether it's a high, mild, moderate, or severe, or crash.
So why do you want to do a MES score?
Sir, in order to assess the severity of the injury, in order to plan our management as well.
So management is more important than severity, isn't it? You want to know whether you can save this hand or not, isn't it?
Yes, sir.
Yeah, so you want to know whether you can save this hand or not. You call the Mengel discriminative severity scoring system. So what is a MES? Describe MES now that you were telling me.
MES consists of 4 criteria, which is the, number 1 is the soft tissue injury, and number 2 is the ischemia, and third is the shock, and fourth is the age. So
okay.
According to this,
so come back again. So पहले भी exam में कभी भी ये नहीं कहना है कि 4 जो है ना उसमें stages होती हैं, 6 stages होती हैं, क्योंकि फिर if you forget the 4th one, the examiner बोलेगा वो चौथी वाली क्या है, तो उसको कहना कि MES is divided into the severity of the injury, the relative ischemia time, the age of the patient, and the blood pressure of the patient. Okay, so कितना उसका blood pressure है कि वो hypovolemia में चला गया है कि नहीं चला गया है, कितनी देर पहले उसको चोट लगी है, क्या उसकी severity और patient का age क्या है. These are the 4 things you say. But in the exam कभी भी 4, 6, 8 classification में नहीं बताना है, वरना वो फिर examiner सारे के सारे सुनने के लिए तैयारी हो जाएगा. So in this patient is old, he's 77 years old. Okay, this patient had this injury 3 hours ago. So he was like that for 3 hours. He's hypertensive at the moment. So he's had a very severe injury, and the injury is such that the hand is nearly amputated. It's only skin tags attaching to it. So what is your decision for this patient?
Sir, according to the scoring system, that I would give that this is a severe crash injury. So I will score it 4.
Why do you say crush injury? There is no crushing here. This is a road traffic accident. So why do you want to use words to get yourself into this? Is severe injury. Okay, don't talk about crush. Crush में तो सब कुछ crush हुआ होगा ना. There is no crushing. They're all just broken. Okay. So this is a.
So it is a severe
injury. Yes.
In his age is about is 77 years old. So it marks it is two numbers again for the age. This is greater than 7. It is 77, and he is hypertensive. It also marks as a 0.
Yeah, he's hypertensive.
And last we comes for the ischemia. So the ischemia score. Yes, sir.
Ischemia time is 2 hours.
2 hours, yes, sir. So we can label that that the ischemia. We can give there's 3 numbers to the for the ischemia. So the total score.
So you will say in the exam, this patient's limb cannot be saved. According to the MES scoring system, this patient will need an amputation. We cannot salvage this hand. Okay.
Yes, sir.
So where will you do an amputation?
The amputation wrist disarticulation, sir.
So what about the bit here? So if you X-ray this, there is a radius that is completely fragmented and this, broken. I don't have the X-ray from it, but the X-ray was totally, completely missing bone. It was on the street. It was not even in the patient. So you would like to do an amputation? Okay. You would like to do an amputation as distal as possible. Why?
In order to save the fingers which are salvageable, for example, the lateral 3 digits.
They're not salvageable. None of them is salvageable. Okay. I've just told you that the skin is only attached to the other part of the hand. There is no bone, nerve, or artery present that can hold this. There are no tendons. So the best option for this person is to either do a disarticulation if the radius is intact, or just a bit more proximal, which is a mid radius on the amputation. Why do you want to leave as much stump as possible? What is the reason for that?
Sir, it will help in the function of the patient, sir.
Function of what, sorry?
Sir, it will help the patient in the functional performance of the patient, sir.
How can you've just amputated him, so how can you help him in function? Sorry, I'm being very mean to you now, isn't it? What it says, the more distal and the longer stump you have, the better orthotics you can put in those patients, and they can have an implant that you can put on them, like the orthosis you have, where you have a patient who can show various type of orthotics. You know what I'm talking about, the prosthesis, as you call them, for these patients. So the bigger the stump is, the better the chance for them to have a function. Okay, one more here, and then I will go to the orthotics. You all want to talk about orthotics seriously, isn't it? Go on.
So, X-ray of the wrist, lateral view of skeletally mature individual, showing the dislocation of the lunate.
Okay, so this is a different person, and this is a different person that shows number 2 and number 1. So should we talk about this one first, yeah?
Yes, sir. So number 1, sir.
Yeah, so you think that's a lateral showing the lunate with no scaphoid in it. So there is something else, it's not very clear on this, but this is a transscaphoid perilunate dislocation. Okay, and this is a perilunate dislocation. Is there a difference between the two?
Yes, sir. In the first X-ray, that leads to DC dorsal intercalatus segmental instability.
Whereas in the second, they're both the same injuries, except one's gone through the scaphoid and one has gone below the scaphoid. Do you know what the Mayfield circle is?
Yes, sir.
What is it?
Mayfield circle, sir, consists of the all the 8 carpal bones that are connected with osseous with the ligaments. They are interconnected with
so it is a pattern of how the lunate dislocates, yeah? So if it goes in a circle and misses the scaphoid, it becomes a perilunate dislocation. If it goes through the scaphoid, it becomes a transscaphoid perilunate dislocation. What approach will you use to fix this? I think we discussed this yesterday. I forget. What approach will you use?
Sir, Wooler approach, sir.
Okay, this is a complicated, complex hand injury, and it's a trauma patient. I would like to get my seniors involved in this. But if I was the person doing this, I would do a dorsal approach. Why do you want to do a dorsal approach?
Sorry, sir.
Yeah, the ligaments, you have to reconstruct the ligament, isn't it? It does not dislocate unless you tear ligaments. Most of the ligaments of the wrist and the dorsum, so you have to fix them from the dorsal side, repair them, reattach them, or brace them. So you will reduce this. If the scaphoid is fractured, you will fix the scaphoid, then reduce this, and then look at the instability pattern. Whichever ligaments are gone, you will actually repair those. We'll talk about intercalated segment stability tomorrow because I don't have slides for them, but we'll do that tomorrow.
Can I ask a question?
Of course.
From unit dislocation. So if you got unit dislocation, you will go dorsal to repair the ligaments and reduce it.
Yes.
But what about median nerve? What about median nerve?
Yes, you can do 2 approaches. You can go from the front to the back also. Sometimes when you're doing from the back, you may not be able to reduce the lunate at all. So you then go from the front, look at the nerve. If the median nerve is symptomatic, release it. If not, go from the front and reduce it. And then you have to repair it dorsally. So do you know the word Ellicott?
do as possible.
Do what you can. It's on the table. You do what you want to. Preferably open it from the back so that you can reach the ligament, which you have to repair anyway. But if you can't do it from the back, you can go from the back and then help yourself from the front, so that you can reduce the whole thing and then stitch and repair the ligaments. Okay, what is this? Final question, then we'll do something else. Yeah.
Sir, X-ray wrist, sir, PA showing the distal radio-ulnar joint and as well as the
well, why do you want to say this in the exam? Why can't you just say this is an X-ray of the wrist showing a non-union of the scaphoid fracture? You know, you have to show that you are a consultant now. You know, not like a student that you will tell and describe things. In the exam, you have to show your confidence. So this is an X-ray of this, the carpal and the radius showing a non-union of the scaphoid. Agreed? Do you agree? Hello?
Yes, sir, I agreed.
Agree, sir.
Yes, sir, I agreed.
Yes, sir.
So show your confidence. You know, don't tell the examiner, you know, describe an X-ray. That's what medical students do, like I said. You are now an FCPS candidate, and hopefully, inshallah, everybody will be passing it, and then you will become a consultant on your own. So you have to show that. You can't just keep describing X-rays, because that's what, when you're in trouble, or when you don't know anything, or when you're a student, that's what you do. So if you don't know anything, go to basics and describe X-rays. But if you do know, show your confidence by saying this is a scaphoid non-union. So what do we do with scaphoid non-union? Come on, there's long gaps, you know. What do we do with scaphoid non-unions?
So,
sir, I will reevaluate with the, well, sir, reevaluate and stage that in which stage the non-union is, and then treat it according to the stage in it. Okay, so that's a very vague answer. What you will say is you will assess whether the bone is alive or not. So you want to know whether the bone is viable or not. What test would you do to tell you if the bone is viable or not? So we perform the MRI, sir. So it'll tell you whether the bone is alive or dead, isn't it? So if the bone is alive, what will you do for this patient? If the bone is alive, I will go for a salvage procedures. What's a salvage procedure? Why do you say all these difficult words? You know, you're waking me up every time. You have to do low flying. You know, stay low, so don't get in the radar of the examiner. Right? Don't use words that you normally don't use in your clinics. So what's the salvage procedure you're going to do? Sir, initially we can just give immobilize the wrist. But it's not going to work because the patient already has non-union, established non-union, isn't it? And there is a 95 to 100% chance that the wrist is going to get arthritic if you leave it unstable or non-union scaphoid. So we agree on that all scaphoids have to be fixed when you see them, especially when they go into non-union. Okay, so the time to give a non-operative management is in the first 6 to 8 weeks. After 8 weeks, you have to do something with it. So I've given you a clue. The blood supply to it is okay and it's not dead. Sir. And I will, sir, open reduction in internal fixation with screw, sir. You will fix this. So where would you go, dorsal or would you do volar? Sir, I will, sir, it depends upon, sir, the involvement of the scaphoid. Well, you can see the X-ray. Why are you saying things like that, isn't it? You can see where the X-ray is, isn't it? So if it's a proximal pole fracture, which this isn't, then you'll go dorsal. Everything else you will go volar, isn't it? So you will go volar with these and fix them, get into to the scaphoid, see where the scaphoid is, freshen the edges, bone graft it, and put a screw across to it. Some people will put a blood supply to it, some people won't. But you can do this, okay? What if the blood is dead, the bone is dead now? So what would you do here? If the bone is dead, sir, and there is arthritic changes, then I will go for the proximal low corpectomy, sir. Very bad operation, okay? But you can do that. That one is the option. They're in lots of pain and they don't have function back again, okay? So if there is arthritis, then you've lost everything. You have to go for fusion. If you haven't got arthritis, you can still do other things. You can do what is called a limited fusion. You can take the scaphoid out, use it as bone graft, and have all these 4 bones come towards the radial side, use the lunate as your function, and you can fix the 4-corner. This is called the 4-corner fusion, yeah? So it is called limited arthrodesis. You take the scaphoid out, bring the lunate more radially, allow the lunate to be the joint. So you have a radial lunate, because the radial lunate is the last bone that goes into arthritis when you have a fracture
in the carpus area. So you use the lunate as a joint. Okay, so you can do a four-corner fusion, or you can fuse the lunate to the radius, which is what a lot of people are doing. The four-corner fusion was having problems. So what people now do with these is take the scaphoid out and fuse the lunate to the radius. If the scaphoid is intact, but you have a scapho-lunate dissociation, which you have in a carpal, a lunate dislocation, what are your choices then? I think I've got a picture somewhere. Just give me a minute. Yeah, something like this. So you have this. What are you going to do here?
Yes, sir. So, okay, sir, I will go again for this, sir, four-quadrant fusion, sir.
No, you can't go for four-quadrant fusion because the scaphoid is not dead, isn't it? So the capitate is a problem here, right? The capitate is driving to bring these two. इनके बीच में तलाक डालने की कोशिश कर रहा है जो आपको radiolunate joint है ना? It is pushing and pushing and pushing and separating them. So what you're going to do is you're going to make a pillar to stop the capitate from coming down. So you will do an STT arthrodesis, scaphoid, trapezium, and trapezoid का pillar बना देंगे ना तो ये flexion नहीं होगी, इससे नीचे नहीं आएगा. When you are doing this operation, you have to make sure that the lunate is not in flexion or extension when you fix this. So you have to reduce the lunate to make sure all these things stop it as a pillar to come down to hold it. So remember that. If you have a problem with the scaphoid, you have to fix it. Before you fix it, you need to do an MRI scan. MRI scan will tell you whether it's alive or dead. Okay, if it's alive, you fix it, it will work, you bone graft it. If it's dead, then if you have a fracture, you take the scaphoid out and do what is called a limited arthrodesis, where you either put the lunate to the radius or you put the four-corner fusion. However, if there is scapho-lunate dissociation and the scaphoid is intact, then what you do is called a pillar procedure, or you do an STT arthrodesis to bring the whole thing together. Okay, that was a difficult question, so don't worry about it. But now you know you will be able to answer this in the exam. Yeah. One more, and then we'll call it a day. Oh, do you know the principles of amputation? How do you reimplant hands or limbs? Should we get somebody else a chance? Yeah, one final person can.
Yes.
Who wants to play now? Or do you want to play still?
Excuse me, sir.
I don't mind. Anybody can play. Just last question, and then we'll call it a day.
Sir, I want to ask. Hello.
What are the principles of reimplantation after traumatic amputation? Do you know the principles?
Can you hear me, sir?
Yes, I can hear you.
Sir, I want to ask about the previous
X-ray.
In which, sir, you said that we should go for fusion.
Yeah.
Yeah, four-corner fusion in this X-ray, sir.
Scaphoid non-union, yes, yeah. So a lot of people are not doing four-corner fusions now. This is a scaphoid non-union. What they're doing is, yeah.
The last one.
Go on, I'm listening.
Sir, the last one you showed, not this one.
So you mean this one, yeah? Scapholunate dissociation, or
Oh, sorry.
This one? No.
No. In which
I'll come. Don't worry. It'll come. It'll come. This one you mean?
Yes, sir, this one.
Yeah, go on then.
Sir, I want to ask that aren't there arthritic changes at the level of the radius in this patient?
Yes, you can do what you call a radial osteotomy at the time or take it out. But you're right, there is. But the point is that this will become a pillar and it will stop the capitate from coming down. So it is a difficult problem to solve it, but the lunate is the last one that goes into arthritis. And if you make a pillar on it, the lunate will come in the middle and work as a joint. However, if you feel that it's too arthritic, then you can fuse the whole thing all together. Proximal row carpectomy doesn't work. There's a lot of evidence to say it doesn't work, but I think everybody in Pakistan does proximal row carpectomy. So for the exam, you may mention it that the proximal row carpectomy is an option, but the results are poor. We're only discussing principles. We're not treating this particular patient. I just want you to know what choices you have if you have a fracture or a scapholunate dissociation. Okay? Good. So should we call it a day, or do you want to talk about amputations? Should we come back
Yes,
tomorrow?
let's talk about amputation and then call it a day.
All right, okay. So who wants to tell me the principle of reimplantation? How do you reimplant? What are the principles? Anybody want to take? Badr is here, Tokir is here, who else is here? Umair is here, Sajjad is here, Salman is here. I don't mind. I know you're not going to do well, and that's okay because we're going to help each other to learn. So this is the whole thing we're doing. This is for you guys to be good enough to do the exam. Okay, everything you can say anything stupid you want to hear because we're learning. But for the exam, this is a practice, and we're going to do this about 3 weeks in a row, every Friday, Saturday, and Sunday, and then hopefully by the time the exam comes in, we're all ready. Even I'm learning for you guys. Don't worry, I don't know most anything. I just learn because I can ask questions, so I can ask you guys to tell me what it is like. Yeah. Nobody knows everything. This is the first thing you must understand. Nobody knows everything.
Sir, the timing of the we can see the warm ischemic time, the cold ischemic time. Less than 6 hours of the warm ischemic time, less than 8 hours of the cold ischemic time.
Okay. So we are now in a stage where we know that this patient doesn't have that much ischemia. This was amputated, and the patient was brought within half an hour in an ice bag to the A&E department. The orthopedics hand surgeon was available, so he said that he will help. This is another thing in the exam. If you get an amputation to implant fingers in hands, you will tell the examiner that this is a super specialty, and people who have got experience should be involved in this. So if you don't say this, you get into trouble. If you say this, you've already scored points, and the examiner is happy. Okay. The warm and cold ischemic time is allowing you to repair this. Plastic surgeon or the hand surgeon has come to help you. So what are the principles? That was my question. So what will you do? Will you do bone fixation first? You will do nerve, you will do vessel, you will do arteries, you will do tendons. How are you going to sort this on?
Sir, we will fix the bone first.
You get stability. Good.
Yes, stability of the bone. If the extensor tendons are involved, we fix the. This is the forearm, sir.
Yes.
I only know the hand, sir. I apologize. So for the extensors tendons, so then we will fix the flexors, then the artery.
So before you do anything at all, you try to do bone stability, but you will make sure that you canalize the artery and do a tube, long tube to connect the vessels. Okay, while you're fixing and you're doing all these things, the blood needs to flow. So what you're going to do is you will, bypass the artery. Sorry? Put a shunt in. Yes, you will do a shunt in first and stabilize it by putting the bones together.
Vascular shunt first.
Yes, because otherwise it's we know good if you fix everything and then you realize there's no blood supply going to it, isn't it? So you do a vascular shunt and you stabilize with bones. What next? You told me you will do the extensors or the flexors first.
Sir, I would like to do the extensors first.
Why? Why do you want to do extensors first? So which is the strongest part of your body? The flexors, isn't it? So if you don't fix your extensors, the flexors will overpower your extensors, and therefore you will have no function at all. So you do the extensors first because you want to make sure the fingers can be extended, because the flexors, whatever you do to them, they will eventually have the power and they'll do whatever you want them to do in this particular. So you're right, you fix the extensor, but you need to know a reason why you want to fix them first. There's no random reason, it's just a reason for them to be fixed, isn't it? So you will stabilize, you will do a vascular shunt, you will stabilize the bone, then you will fix the extensors, then you will fix the flexors, and the nerve comes last. Okay? Agreed?
Agreed.
Yes. Okay. Fine. Well, I think I've copied this all down on a video, so I'll post it on the forum for you guys to go and look and see it again. When we finish this week, then I'll post you all the slides so you can play with it. Okay? But yeah, I hope it helps you. I want you guys to pass. I mean, there's not much I can do sitting here and you guys are there, but maybe this is an alternative where you can practice with me. The key is you sit with your friends and colleagues and talk. Exam mein knowledge sabke paas hoti hai, wahan bolta koi nahi hai. So if you don't tell the examiner will say that you don't know. Okay? So bolne ki practice kare, ek dusre ke samne baith ke na practice kare bolne ki. That is what is very important for this exam. Most examiners, people don't fail because they don't have knowledge, they just fail because they can't talk. And that's why we're doing this, so you guys can talk. And that's why I want everybody to talk. I know a lot of you are very good at it, and some of you are okay with it, and some of you don't want to talk. But if you don't talk, you can't pass the exam. उसके पैसे भरे हुए हैं, पैसे भरे हुए हैं तो वापस तो चाहिए होंगे, उसका रिजल्ट दिया होगा कि आपको इम्तिहान पास करना है. Happy? Come back again tomorrow?
Yes, sir. Thank you very much, sir.
Tomorrow सुबह जो है ना हमारा 9 बजे यहाँ पे पाकिस्तान के 2 बजे करीब हम लोग हिप आर्थ्रोस्कोपी पे सेशन हो रहा है. If you guys want to join in, by all means, like Vin said, it is not for your exam, but it is just to tell you what a hip arthroscopy looks like. Sports forum ka meeting ho rahi hai. Okay.
Okay.
I'll see you guys tomorrow. Yeah.
Okay, sir. Thank you very much, sir.
Thank you, sir.
Thank you.
Thank you, sir.